Hi guys, did you know that the chest X-ray is the most common requested radiograph in hospitals? It is almost crucial that every doctor knows how to read a simple chest X-ray, and since you will probably see hundreds if not thousands of chest X-rays in your rotations, let's try to get a better hang of it. Now, before we jump into all the different pathologies identified on radiographs, we need to go back to some basics. The first thing that we see on an image is the way it is viewed. The standard view is a PA or posterior anterior erect chest X-ray. This means that the X-ray source is positioned so that the X-ray beam enters through the posterior aspect of the chest and exits out of the anterior aspect. Usually, when requesting for an X-ray, a PA view erect is asked for. But why is this? Well, there are a few reasons for this. The PA view is done for accurate assessment of the cardiac size due to minimal magnification. Also, the scapula can be rotated out of the way. The reasons for performing the film erect, which means standing upright, includes the gas moving upwards, so any free air underneath the diaphragm are more easily diagnosed. The fluid passes downwards, so any of the fluid is also more easily diagnosed. Physiological representation of blood vessels and lungs, if it were taken in the supine position, in other words, lying down, the mediastinal veins and upper lobe vessels of the lungs may be more distended than normal, leading to the misinterpretation. So what are the other views and why are they used? AP or anterior posterior or supine chest X-ray is performed when the patient is too ill to stand, like patients in the intensive care unit or A&E resuscitation. The major disadvantage of AP supine films when compared to PA films is that the mediastinum and cardiac size will appear wider on an AP supine film due to venous distension and magnification. Therefore, you should not comment on the cardiac or mediastinal size on an AP supine film. Another view is the lateral chest X-ray, which is used to give further views of the contours of the heart and the inferior vena cava, which is seen entering the right atrium, and more details of the anatomical location of lesions, however. This is rarely performed now as CT gives more information. Expiratory PA erect chest X-ray is used rarely for helping to detect a suspected pneumothorax or suspected bronchial obstruction with air trapping. So let's move on to identifying some structures. On a normal chest X-ray, darker colors indicate less dense material and lighter colors indicate more dense material. The lung appears black because they are spongy with a lot of air content. The bones appear white because they are hard, mineralized, and block X-rays effectively. Remember, as you look at a chest X-ray, the left side of the radiograph is the patient's right side, and the right side of the radiograph is the patient's left side. A good way to remember this is to imagine that the patient is always facing towards you. Both the right and left lungs are visible, but are the darkest parts of the X-ray since they are the least dense. The rib cage is visible as both the anterior ribs and posterior ribs. We can also see the clavicle, the right costophrenic angle, the left costophrenic angle, both the right and left hilum. This is where the bronchi, arteries, veins, and nerves enter and exit the lungs. And the normal lung vascular pattern can be seen as arteries and veins that branch vertically to upper and lower lobes. Now, an important structure to note is in fact the mediastinum. The mediastinum is the central compartment of the thoracic cavity. It contains the heart, the great vessels, the esophagus, the trachea, the phrenic nerve, the vagus nerve, the sympathetic chain, the thoracic duct, the thymus, and the central lymph nodes, which also includes the hilar lymph nodes. Important structures you need to identify apart from the trachea and heart include going down the right side of the silhouette, we have the superior vena cava, the right atrium, the inferior vena cava, And going down the left side, we have the aortic knob or arch, representing the part of the thoracic aorta arching backwards over the left main bronchus and pulmonary vessels. Other than that, we have the pulmonary aorta and the left ventricle. Now, neither the left atrium nor the right ventricle is visible on the normal chest radiograph. This is because the right ventricle lies anteriorly and the left atrium lies posteriorly, and they therefore have no definable border on a chest X-ray. Now, coming to the presentation of a chest X-ray. In order to present a chest X-ray, you should always try to do it in a systematic way to ensure you cover all areas and do not miss anything important. This is how it should be presented. Give the type of radiograph and projection, give the patient's name, give the date the X-ray was taken, briefly assess the film quality to ensure it is adequate, commenting if there is any rotation or inadequate inspiration, run through the ABCDE of chest X-rays, and then give a short summary at the end. Now, what do I mean by the ABCDE of chest X-rays? Well, the A is for the airway, B is for breathing, C is for circulation, D is for disability, and E is for everything else. But we'll get into those in just a minute. Now, for an example, this is a PA chest radiograph of Mrs. NR taken on the 18th of June 2020. The film is not rotated and there is adequate inspiration. Now, in airway, the trachea is central. In breathing, the lungs are uniformly expanded and the lung fields are clear. In circulation, the heart size is normal. There is no mediastinal shift. The mediastinal contours and hyla appear normal. In disability, there is no fracture or bony abnormality. And in E, there is no evidence of air under the diaphragm, surgical emphysema, or any foreign body. So in summary, this is a normal chest radiograph. All right, guys, so now we're done with the normal chest X-ray and how to read it. Now next, we're going to go into the ABCDEs in detail and as well as discuss some important radiographic points on common pathologies, so keep watching. Now, there is no one way to go about approaching a chest X-ray, but it's probably a good idea to go by the ABCDE approach we just mentioned. So first, we'll talk about the airway, where we look at the trachea and look for any tracheal deviation. Now, this is what a normal, centrally placed trachea looks like. And this X-ray of a pneumonectomy shows clear tracheal deviation. If you suspect that the trachea is deviated, look for a possible cause. Now, conditions where the trachea is deviated towards the diseased side include lung collapse, pneumonectomy, which is a removal of a lung, unilateral fibrosis, and agenesis of a lung, which is also called lung aplasia. Conditions in which the trachea is deviated away from the diseased side include tension pneumothorax, a large pleural effusion, mediastinal masses, and paratracheal masses. Now next, we'll look at the breathing. Are the lungs uniformly expanded? Compare the lung fields and look for any white areas or shadows. Look around the edges of each lung. Look at the costophrenic angles and look for the four silhouettes: the right heart border, the left heart border, the right hemidiaphragm, and the left hemidiaphragm. Now, chest X-rays do not show many specific diseases, only signs of pathology, which can give a clue to the underlying disease process. The following are a list of pathologies and signs that you should know: consolidation, collapse or atelectasis, pneumonectomy, mass lesions, cavitating lung lesions, fibrosis, pneumothorax, pleural effusion, and pulmonary edema. Now first, we're going to talk about consolidation or air space shadowing, which is replacement of alveolar air by fluid, cells, pus, or other materials. Pneumonia is by far the most common cause of consolidation. It is also sometimes seen in primary tuberculosis. Now, the features of consolidation include patchy shadowing, lobar segmental density, and no loss of lung volume. Now coming to collapse or atelectasis. This is a failure of all or part of the lung to expand due to loss of air in the alveoli. Some causes of a collapsed lung include consolidation, like a pneumonia, bronchial obstruction by any means, like endobronchial tumor, mucus plugging, or any inhaled foreign body, and external pulmonary compression. Now, general features of a collapse on a chest radiograph include an increase in density representing lung devoid of air, as shown in this image of a right upper lobe lung collapse. And a complete left lung collapse is also shown, which shows signs indicating decreased lung volume, such as displacement of the mediastinum or trachea towards the collapsed lung and elevation of the hemidiaphragm, as well as compensatory overinflation of adjacent lobes or the opposite lung. Now let's look at pneumonectomy. Pneumonectomy is an operation to remove a whole lung, which you would know from obtaining the patient's history. Radiological signs of a previous pneumonectomy include diffuse haziness and loss of hemidiaphragm where the lung has been removed from, mediastinal or tracheal shift towards the side with no lung. Now, you can't differentiate between a pneumonectomy and a complete lung collapse on a chest radiograph, as they may both look the same. Now, moving on to mass lesions. These can be either solitary, multiple, or cavitating. Looking at solitary mass lesions first, the term itself is used to describe a discrete area of whiteness situated within a lung field. The main worry is that it could be a carcinoma. The radiological factors to assess are the size, greater than 1 centimeter in diameter makes the lesion significant. The margins could be irregular, lobulated, or spiculated margins that suggest malignancy. Calcification, that would appear dense white like bones, but these are more rare in malignancies. Comparing with a previous chest X-ray to assess the growth is crucial. Look for other solitary mass lesions. The differential diagnoses are neoplasms, benign mass lesions, and infections such as tuberculosis. Now, in multiple mass lesions, these can either be metastasized, abscesses, rheumatoid nodules, or Wegener's granulomatosis. When it comes to cavitating lung lesions, now the solitary mass lesions may sometimes cavitate, causing a cavitating lung lesion, which is a hole in the lung with a wall, lumen, and contents. The causes of cavitation include abscess, neoplasm, cavitation around a pneumonia, fibrosis, and rarely rheumatoid nodules. Moving now to fibrosis. Fibrosis is thickening and scarring of the interstitium or connective tissue of the lung. The causes of interstitial fibrosis include sarcoidosis, and using sarcoid as a mnemonic, there's S for systemic sclerosis, A for asbestosis, R for rheumatoid, C for connective tissue disorders, O for occupation, such as pneumoconiosis or extrinsic allergic alveolitis, I for idiopathic pulmonary fibrosis, which is usually interstitial pneumonitis, D for drugs such as methotrexate and amiodarone. Other than that, we have bronchiectasis, tuberculosis, and radiotherapy. Now, radiological features of reticulonodular shadowing include the reticular shadowing, which is produced by the thickening of the lung interstitium or connective tissue, seen as a fine or coarse branching as a linear pattern. The heart loses its normal smooth outline and seems shaggy. The nodular shadowing, which are small discrete opacities, are also present. Next, we have the pneumothorax. Now, a pneumothorax is air which is seen as black in the pleural space. Radiological features to look for are that one side is blacker, the one that has no lung in it. The lung edge is seen and there are no lung markings beyond the lung edge. Check for a mediastinal shift. Shift of the mediastinum away from the side of the pneumothorax indicates a tension pneumothorax. And more prominent vascular markings are also seen in the opposite lung. When talking about tension pneumothorax, this is a serious type of pneumothorax whereby air enters but cannot leave the pleural space. This can lead to a complete collapse of the lung and is a medical emergency. It is a clinical diagnosis, which means it should be diagnosed on the basis of history and examination and not radiologically. The radiological features to look for are darkening of the hemithorax and loss of lung markings due to air in the pleural space, an increased volume of the hemithorax, displacement of the mediastinum and trachea away from the pneumothorax, and a depressed diaphragm. Talking about hydropneumothorax now, a hydropneumothorax is air and fluid in the pleural space. An erect chest X-ray will show an air-fluid level. The causes of hydropneumothorax can be iatrogenic, usually by introduction of air into the pleural space during a pleural fluid aspiration or chest drain insertion. It can also be due to trauma or presence of a gas-forming organism, which is still a rare cause. Let's move on to the pleural effusion. A pleural effusion is the accumulation of fluid in the pleural cavity, which is a space between the parietal and visceral layers of the pleura. Although the causes of pleural effusion can be transudative, exudative, blood, lymph, or pus, they all look the same on a chest X-ray. Now, the classical radiological appearance of a pleural effusion include a homogeneous dense opacity, the loss of the costophrenic angle, a meniscus, therefore the upper border will be concave, and the loss of a hemidiaphragm. Now, a hemothorax looks the same as a pleural effusion on a chest X-ray. The cause of a hemothorax is usually traumatic. A blunt or penetrating injury to the thorax results in a rupture of the parietal or visceral pleura. Other than trauma, a hemothorax may occur as a complication of pneumothorax, pulmonary infarct, or anticoagulant therapy, which may potentiate the ability of a chest injury to cause a hemothorax. While pleural effusion is caused by conditions like congestive heart failure, pneumonia, and pulmonary embolism. Now let's talk about pulmonary edema. Pulmonary edema is fluid accumulation in the lungs that causes flooding of the alveoli with fluid. This causes severe disturbance of gas exchange across the alveolar surface and can lead to respiratory failure. But wait a second, how is this different from a pleural effusion? Well, pulmonary edema differs from a pleural effusion because in pulmonary edema, the fluid is in the alveoli, and in a pleural effusion, the fluid is in the pleural space. Now, some causes of pulmonary edema include cardiogenic causes such as heart failure. Now, the failure of the heart to remove fluid from the pulmonary circulation in conditions such as left ventricular dysfunction or mitral valve diseases, and non-cardiogenic pulmonary edema can be caused by renal failure with fluid overload, iatrogenic fluid overload, or an adult respiratory distress syndrome. The radiological appearance of a pleural effusion include a symmetrical diffuse fuzzy shadowing, especially in the mid and lower zones where the pulmonary venous pressure is highest due to gravity, provided the patient has been upright, of course. Other than that, upper lobe blood diversion can be seen. Now, vessels in the upper lobe are larger than the vessels in the lower lobe on an erect chest X-ray. We can also see peribronchial shadowing, where the bronchi are thickened when viewed end on. This is a radiographic sign occurring when excess fluid builds up in the small airways, causing localized patches of atelectasis. We also have perihilar haziness. This is a hazy shadowing around the hilar regions. And in acute cases, you may see the characteristic bat's wing pattern, in which the opacity takes the shape of a bat's wing. Now, you may have to use your imagination here. We can also see some septal lines that are caused by the engorgement of pulmonary interlobular septal lymphatics. They are invisible on the normal chest radiograph, but they only become visible when thickened by fluid, tumor, or fibrosis. So the causes of septal lines include the interstitial pulmonary edema, from pulmonary venous hypertension secondary to heart failure, also by lymphangitis carcinomatosa, and fibrosis in pneumoconiosis. And that concludes the airway and breathing aspect of the chest X-ray. Now we come to C for circulation. The first thing we have is dextrocardia. In this condition, the heart is in the right hemithorax, with the cardiac apex directed to the right. Basically, the heart is in the wrong direction. Next, we have cardiomegaly, which is the enlargement of the heart. Now, if the width of the heart is more than half the total width of the thorax, the patient has cardiomegaly. The width should be measured horizontally and is the longest possible distance between the left and right heart borders. The most common reason for the heart to be enlarged is heart failure. Next up, we have the left atrial enlargement. Now, the left atrium may be seen on a PA chest X-ray as a left atrial appendage. The left atrial appendage is normally concave in shape, but if the left atrium is enlarged, which is usually secondary to mitral stenosis, there is a loss of concavity and straightening of the left atrial appendage. Sometimes atrial enlargement is so great that the left atrial appendage bulges outwards. Next, we have widened mediastinum. Now, the important causes of a widened mediastinum include aortic dilatation, which is usually by aortic aneurysms or dissection. We have lymph node enlargement. We have dilatation of the esophagus, thyroid enlargement, and thymic tumors. Moving on to hilar enlargements, this can either be unilateral or bilateral. Now, the three causes of unilateral hilar enlargement include an enlarged vascular shadow, which is caused normally by a pulmonary artery aneurysm or post-stenotic dilatation of the pulmonary artery, enlargement of the hilar lymph nodes, which is caused by infections such as tuberculosis, which are spread from primary lung tumors, primary lymphoma, or sarcoidosis, which are rarely unilateral. And third, we have the central bronchial carcinoma superimposed over the hilar shadow. The two causes of bilateral hilar enlargement include pulmonary hypertension, which can be caused by obstructive lung diseases such as asthma or chronic obstructive pulmonary diseases, left heart diseases such as mitral stenosis or left ventricular failure, left to right shunts, which include atrial septal defects and ventral septal defects, recurrent pulmonary emboli or primary pulmonary hypertension, and secondly, bilateral enlargement of the hilar lymph nodes. This is caused by sarcoidosis, an infection from tuberculosis, spread from primary lung tumor, or a primary lymphoma. And lastly, we have the hiatus hernia. Now, this is a herniation of the stomach into the thorax. On an erect chest X-ray, it appears as a mass behind the heart with an air fluid level. So that was all about C for circulation. Keep watching for the other parts, which are D for disability and E for everything else. Now we're moving on to the D for disabilities. We're looking for any rib fractures and other bony abnormalities. Follow the edges of each bone to look for fractures. Look for areas of blackness and compare the density of the bones on both sides. They should be the same. Are all the ribs present? If not, they may have been removed during a previous thoracotomy. Are all the ribs intact? Look for any possible fractures. Now we'll move on to E for everything else. We're looking for air under the diaphragm or gas under the diaphragm, which is also called pneumoperitoneum. Pneumoperitoneum literally means free air in the peritoneal cavity. It indicates perforation of an intra-abdominal hollow viscus. It may also be seen soon after laparotomy and laparoscopy. Now, normally the area immediately under the diaphragm is white, since the upper part of the abdomen contains the dense structures of the liver and spleen. A pneumoperitoneum is therefore seen as black space just under the diaphragm. The erect chest X-ray is a very sensitive investigation for detecting free abdominal air, since it can detect as little as 10 milliliters. The main causes of intra-abdominal perforation include perforated peptic ulcer, a perforated appendix, a perforated bowel or bowel diverticulum, post-surgery, and trauma. Now we move on to mastectomy. Now, it is important to remember that problems outside the lung can sometimes cause the lung fields to look too black or too white. A mastectomy is the surgical removal of one or both breasts and will make the underlying lung look too black. Therefore, if one lung looks blacker than the other, look carefully for the breast shadows. There will be an absent breast shadow on the side of the mastectomy. Now moving to foreign bodies and medical interventions. There are a number of common examples that you should be able to recognize, such as the cardiac pacemakers, breast implants, or a coin stuck in the esophagus, as well as the nasogastric tube on the chest X-ray and the tracheostomy tube. And that concludes our video for disabilities and everything else. Now, when coming to the normal chest X-ray, you must know the following common conditions and their radiological signs. The first one we're going to go through is the bronchial carcinoma. The radiological features include a lobulated or spiculated mass, but sometimes with a smooth outline. It may be associated with hilar gland enlargement, pleural effusion, or areas of collapse or consolidation. Cavitation can be found in 15% of patients, since squamous cell carcinoma frequently cavitate. They may also see metastases. Moving on to heart failure. The radiological features associated with heart failure include cardiomegaly, pulmonary edema, upper lobe blood diversion, which is basically vessels in the upper lobe that appear larger than vessels in the lower lobe on an erect chest X-ray. This is due to increased pulmonary vascular resistance in the lower zones due to dependent edema. We also see septal lines due to fluid in the lymphatics, and pleural effusions, which is fluid leaking from the vessels into the pleural space. Next up, we have pneumonia. On a chest X-ray, pneumonia appears as consolidation or airspace shadowing. Other occasional features of pneumonia on a chest X-ray include pleural effusion or cavitation. Let's move on to the chronic obstructive pulmonary diseases. Now, if COPD is suspected, we're looking for the following features. A pneumothorax, which is common in COPD, so we have to look for these since they can hide in the lung apexes. We're also looking for a mass lesion or metastasis or any other sign of lung cancer. A history of smoking is almost universal in COPD, so look for evidence of bronchial carcinoma. Next, we have tuberculosis. Now, tuberculosis is an infection most often caused by a Mycobacterium tuberculosis, affecting mainly the respiratory tract, though it can involve any system in the body. Now, tuberculosis has various manifestations in the lung and often presents in the lung episis. There's a lot of crossover between the radiological appearances of primary TB, secondary TB, previous or old TB infection, and also miliary TB. So let's go through them. The radiological appearances of the primary TB include peripheral lung mass or consolidation, which is known as the Ghosn focus, and enlarged hilar lymph nodes. In secondary TB, which is also known as post-primary TB or reactive TB, we see consolidation, often with cavitation, especially in the upper lobes or apical segments of the lower lobes, that may be associated with pleural effusion or pleural thickening. Now, previous or old tuberculosis, this is a healing progress, and the features that you can recognize are fibrosis and volume loss, calcified foci, pleural calcification, and tuberculoma. Last, we have the miliary tuberculosis, which are discrete 1 to 2 millimeter nodules distributed evenly throughout the lung fields due to the hematogenous spread. Next, we'll talk about asbestosis. Now, asbestosis is a term for the interstitial fibrosis that develops in approximately 50% of patients with industrial asbestos exposure. It is a chronic inflammatory condition affecting the interstitial tissues of the lungs, occurring after long-term heavy exposure to asbestosis, usually from mining. The radiological features include fibrosis with some volume loss and pleural calcification, areas of patchy calcification seen relating to the diaphragm and also along the anterior chest wall. Now, the last condition we're going to discuss is mesothelioma. A mesothelioma is a malignant tumor that develops in the pleura, usually unilaterally, and causes pleuritic type of chest pain. 5 to 10% of asbestos workers develop malignant mesothelioma. It has a latent period of 20 to 45 years. On a chest X-ray, it gives characteristics of pleural shadowing and evidence of chest wall invasion, or metastasis. The radiological features include the spread of whiteness that does not follow the lung lobe boundaries as it is pleural in origin. The edges of the whiteness are lobular in nature, so there should be no meniscus. This is because the main differential diagnosis to rule out is pleural effusion. There may be loss of lung volume on the affected side, which increases our suspicion of mesothelioma. Evidence of a chest wall invasion, which is rib destruction or a soft tissue mass in the chest wall, may be the only feature to differentiate mesothelioma from a benign disease. And that's it. We've now gone through a normal chest X-ray, how to present it, the airway, breathing, circulation, disabilities, and everything else, as well as some common pathologies. For more videos like these, keep watching Scadia.com.